everyone understand that when a person comes into a clinic, and we are looking at, do they have valvular disorder? Do they have something going on with them? They'll put it, they're here to rule something out. Y'all understand that? And then if they've had a procedure or a surgery, they'll say status post. And that means they just had that procedure or they just had that surgery. They may say status post 2 days. That means they had that surgery 2 days ago. Does that make sense? I just want to make sure you understand that because it never fails in level 3 when we start testing on any system. I get this frantic in a test. I don't know what rule out means. I don't know what status post means. And I know y'all may, but it just stresses me out every semester to see y'all stressing out. So anyway, there's one more. I told you I swapped to using all the other instructors' PowerPoint. And it bothers me because there's something that's not big enough for my liking on the slide. And it's the TEE portion. So what does TEE stand for? Trans means what? Through. Trans means through. Esophageal. Where's the tube going through? Their esophagus. Echocardiogram. And so I need you to understand that is very testable because your patients who are having, we're going to talk about this today, cardioversions many times end up with a 2-for-1 special. So they go to the cath lab and they get a TEE first. And the reason for that is they're looking in the atria, especially the back part of the heart, to make sure there's no clots in the heart before they do a cardioversion. And the most common thing they're doing cardioversions for is atrial fib. Remember, it's the most common arrhythmia, and especially the most common chronic one. Now, if it's chronic, likelihood is the cardioversion is not going to work. So we do that a lot of times when we find the atrial fib, and it's not, the patient hasn't been in it for long, and they're trying to get them out of it. Okay, they're trying to shock them out of the atrial fib. But I brought up TEE because it wasn't on their PowerPoint very boldly. And when something's not on a PowerPoint boldly, I've learned that students don't think much of it. And so have I made you understand that the TEE is something that's highly testable everywhere? And I want you to tell me why you think that is a safety issue.
Swallowing, aspiration.
Swallowing, aspiration, and why would that be?
Because you're going down.
You're shoving a tube down their throat, but we are a little humane nowadays, so they're going to numb the back of the throat before they shove that tube back there. And it's a spray that kind of smells like bananas to me. And if you ever see it, you'll have that same smell in your head forever if you get to assist with one of them and are kind of a little scared. I'm scared because you have to shoot bubbles into a patient's vein. And what do we know about bubbles? Terrible. And you go, you want me to do what? You know, and they're like, I need you to do this. I'm like, I don't think I should do this. They're like, yes, you should do this. And that is okay. And that is how the test works. But I was scared to death my first time, and that smell of banana just kind of makes me nauseated to this day because I guess I have a connection because I thought I was going to kill the patient. But anyway, the big thing with TEE is, number one, prepping the patient, making sure they were NPO. Because what's going to happen if you go shoving a tube down their throat and they really did stop and get a Hardee's biscuit?
They're going to throw it up.
They're going to throw it up. And the likelihood is they could aspirate that into their lungs and die. And you think people understand stuff, but they don't. I've worked in a lot of outpatient areas, And I have one man in mind a couple of times. I've seen the same man, but it wasn't the same man. Walking in, talking to me, smoke still coming out of his mouth. You know, no, I ain't smoked. Look, you're like, well, what's that? And then he says, smiles, because I say something, and I see sausage biscuit all in his tea. Or something. Well, like sausage biscuit to me. And so, smoky sausage biscuit. But anyway, and I'm like, have you eaten anything? No. I'm like, well, what is that in your teeth? Oh, I ate that last night. No, you didn't. Because it wouldn't be still in your teeth. You do understand that if we shove this tube down your throat and there was food in your stomach, that you could vomit and it sucks into your lungs and you're going to die. Do you understand me? And he's like, well, I guess I did have a sausage biscuit. And I'm like, well, I think we need to reschedule. And so it's important that you as the nurse can be a good advocate to patients. Because they don't understand. They don't understand. They think, well, that's stupid that they don't want me to eat, and I'm hungry. So just make sure that you understand that could kill them. And so NPO is important. Making sure that after the procedure, they have a gag reflex before you allow them to consume anything. Does that make sense? Because if you deaden their gag reflex, not everybody's gag reflex returns at the same time. All right? We expect it to, but it doesn't always, especially if we had difficulty getting it numbed in the first place. Does that make everybody good with that? Mm-hmm. The next safety issue is the same man swears there's somebody out in the car to drive him home in his outpatient. And nowadays we have a lot of things in place that we say, till I see this person, you are not going for this procedure. I have to see this person because they need a driver. Because there's been many of a lawsuit on people who say they've had a driver after we've sedated them, and they go get in their car and they get in a wreck and they hurt themselves or others, and then they sue the facility because they didn't have a driver and they got in that car and went and caused injury. Does that make sense? Mm-hmm. So what are the two big safety things for the TEE? And so where is the tube going through? And I hope that makes sense to you that your esophagus sits behind your heart. And with a transthoracic echocardiogram, we can't see the back side of the heart. We can only see the front side. So in order to see the back side and make 100% certain that there's no clots or abnormalities on that back side, we really should do a TEE so we can look at the back side of the heart and make sure. The most common reason we do a TEE is just that, is looking at that back portion of the heart, especially for clots. Because if someone has a clot in their atria and we didn't know it because we did just a transthoracic echo, then we shock them back into a sinus rhythm and it squeezes down. Where's the clot going to go? It's just according to which side it's on and which clot moved, right? Okay. So you got the TEE. We need a gag reflex before we let them have anything. And we let them eat just about whatever. We tell them you probably should eat soft food. You know what I mean? After it. But we don't limit them at all. Other than we make sure they have a gag reflex. And I'd probably give them a little water first. But we don't limit their diet. Okay? So they need a gag reflex and a driver. Got it? Okay. All right. So we've already discussed heart failure. And I know that y'all are shortening your studies sometimes when you work and you got all kind of things. And you think you covered it in level 2. But there is a spot that if you don't read it, you ain't going to do good in life in general as a nurse. And you're not going to do good on this test or NCLEX. So on page 704, and I've got it written up here, so if you don't catch what I'm saying, you can get up here and take a picture or write it. Table 35-4 talks about mods MAWDS. MAWDS. And that tells you about the importance of teaching the patient with heart failure and the things that we should cover. It's like a core measure that we have to do 100%. And so make sure you look at that. And also there's an action alert box on page 704 that you need to read. So don't miss that. And then it hit me, but I had a question from another student. And I thought, well, if they don't know it, my students don't know it. So I thought, I'm going to show this. See, I'm going to throw this out there and see if you know the answer that a student in another section asked me. They said, I don't know that I understand Mona. And I said, Mona is what we do for acute coronary syndromes when a patient comes in, that's an immediate treatment. And she said, yeah. I said, well, why are we doing it? What is the priority? And that's what she was asking me. So why are we doing Mona when a patient comes in with chest pain and we suspect it's either unstable angina or an MI?
Stop muscle damage.
So you're getting there.
To save the muscle.
You're getting there. So let me make sure. Think about Mona. That's not the right order, but we'll go with it. M is
Morphine.
what does morphine do?
Decreases preload and afterload.
Decreases the pain, and it decreases preload and afterload. So when someone comes in and we're doing Mona because they're having an MI or they have unstable angina, the whole priority of that is to reduce pain and decrease myocardial oxygen demand. Does that make sense? Because morphine, it does a lot of things. It's a wonderful drug. Decreases pain, vasodilates, decreases preload and afterload. And why we're doing it is to reduce their pain, and we're also trying to decrease the demand on the heart muscle itself. So that's the whole priority behind that, and that's what we're trying to do when an MI patient or unstable angina patient comes in. And so since there were some questions about that, I always say sweep under your door first. You know what I'm saying? So just because they were asking me, I just happened to be the person in the hallway, and they were studying. And I thought, well, you know what? Mine may not know that either, so let me just bring that back. Because I find when one of y'all has a question, usually a lot more people have that same question. Okay? Cool. So the other thing that was asked by the instructor that is relatively new, I thought was interesting. She's not new to cardiac, she's new to teaching this and the books and all. And you know how I give you a lab PowerPoint and it had ABGs and I kind of grade out the lactate or lactic acid level on the ABGs? I do that because it's so confusing to you. Because I realize you don't know something. In practice, we can get a lactic acid level on ABGs, which are arterial blood. But when we're talking about sepsis, we're talking about a serum lactic acid, which is venous blood. And it's very different. The levels are very different. And so, because according to the facility that you work at, labs are all different. They'll make you crazy. I'm going to just give you this for rule of thumb. Just rule of thumb. Because I found last semester, after cardiac, working at clinical, my students were like, but Miss Cooper, I don't get it. And then I realized this is why you don't get it. Rule of thumb for a serum lactic acid, just write this down, is 0.6 to 2.2 millimoles per liter. Okay? 0.6 to 2.2 mmol, which is millimoles, mmol per liter. Okay? Because there's something that they read in their book, and I got an email going, but the lab PowerPoint, and I was like, where are you getting a number? I don't even have a number on the PowerPoint for this, on purpose. So I tried that approach first, but now I realize as you're reading, if you start taking it all in, you might confuse yourself. So I decided, okay, I'll throw this out there to give them a kind of a measuring post. So serum lactate, when we're talking about sepsis, we're talking about venous blood, where they drew it out of the arm. Normal, 0.6 to 2.2. You good?
Mm-hmm.
And let me just throw this out at you and explain why the student was confused. Was because when a patient's venous lactate or lactic acid, same thing, is greater than 4, we get extremely concerned that they're going into septic shock. And if you looked on the ABG PowerPoint, it said 3 to 7, but that's a completely different animal when we're talking about ABGs. All right? You with me? So you understand why that student might have gotten confused in her study? And so if you got that deep with it, I didn't want you getting confused. All right? And Ms. Cooper's just happy if you know to look at a patient's lactic acid level when you're dealing with a patient you think is infected. I'm not going to test you on that number. If I didn't put it on your lab PowerPoint in the beginning, you're not going to have that number. But is it an important number if you care about your patient and you want to be a good nurse?
Mm-hmm.
Yes. So if you want to pee Miss Cooper off, raise your hand and ask me if it's on the test. I'm going to tell you as much as I can tell you to make it good for you, but it really hurts my feelings when I hear a student constantly doing that, because it makes me think, you don't care about the patient. You really don't care about the disorder if you're not interested. Does that make sense? Because this patient, you are going to see a lot. It's the number one thing that's killing patients in a hospital right now. So I am going to take some time to talk about it in the classroom. There's videos that I have that are extra. There's also a video in this classroom PowerPoint. I'm not going to waste my time with you to show you a video that you can go watch at home. It is, the other section told me that it made them cry, so it must be good. And so watch it if you want to, if you have the extra time. Especially if you don't understand sepsis, you should be watching these videos. All right, one other thing before I move off of your Canvas site. I'm on your module page of your Canvas site. As I'm scrolling, do you see dosage cow? I have opened up, it's green, so that means you can see it, the remediation packet. If anybody needs the remediation packet, because you have to do it, I would do that packet and then go meet with Jennifer Hurlbert or Cynthia Evans here and make sure I had it all right and understand if I'm doing something wrong. Don't expect Ms. Cooper to correct your dosage cow, because you'll be asking me what kind of voodoo are you doing to get to the answer. Because I learned it 1 trillion years ago, and I do it very strange. And so you don't want me helping you. So I can tell you if it's right or not, but that'd be about it. And so Dr. Hurlbert is the expert, and Ms. Evans and Ms. Ehrman. So that's what I got to say about that. Now let's get to this PowerPoint, but I have written stuff all over the board. Why do I do that? To make sure you understand, because I know this is something that my students have struggled with over the past semesters, or that somebody has already emailed me about. So I just want to make sure that I cover this up on the board. So if I don't, holler at me, okay? This is the classroom PowerPoint that I'm pulling up, and I don't want you to think that I'm pulling something that you don't have. I'm on your site. And I say that every semester because somebody will swear I was using something they didn't have. Oh, gee whiz, what's that touch? Oh, you guys. Crazy. So, tell me, because this is just my curiosity, what content area are you struggling with the most? Have you not even looked yet? Not sure yet. Anybody? You think valvular disorders? You'll be shocked when and see, I wouldn't have suspected that, so I needed to hear that. That's hilarious. We haven't gotten there yet.
That's why it's hard.
Okay. Remind me to show you junctional.
But she's not to look at it anymore.
Remind me to show you junctional, okay? All right. Don't stroke out. I told you we were going to start with this. If reading EKGs is your weakness, you need to go and take some time to learn how to do it. And there's all kind of videos. Sarah RN has some. Skill, my favorite that I like to play on is skillstat.com because it has like all kind of rhythms that we haven't even looked at yet. I was telling someone when we talked about SVT that's a big umbrella term for all of the narrow complex tachycardias, and I will show you that. And I couldn't even think of all of them, but like multifocal atrial tach is one, Wolff-Parkinson-White is one, reentry tachycardia is one. So SVT is this huge umbrella term. So if we don't know what we're looking at, we say SVT. And so most nurses use that term because they're not cardiac experts. The only person that can truly tell you exactly what the SVT is, where it's coming from, is a cardiologist. And they argue amongst themselves. You'll be in the unit and they'll almost fist fighting over where, who cares? We're going to treat it the same. Really? So I want you to relax. If you go to skillstat.com and start seeing things you don't know, you'll learn it over time. Let it go. You need to know SVT, okay? Not for your test, just because a lot of people come in with that, and you need to kind of start getting an understanding of it, okay? All right, so let's talk about EKG. When we're looking at EKG, we're looking at EKG or graph paper. So there's little bitty boxes and there's heavily lined boxes. Do y'all remember that? The little bitty boxes are worth how much?
2.
Nope.
0.2.
Nope, the itty bitty boxes. 0.3. Yeah, high five. You're kicking it today. She's awake. No, Miss Cooper's not. Okay, the little bitty boxes are worth 0.04 seconds. And Kelsey does Miss Cooper's cheat method. So she knows, I'm giving her the benefit of the doubt, that 5 itty bitty boxes, so if you take 5 and multiply it times 0.04, what do you get? 0.20, which is where Kelsey was going. Because in the ER, they ain't got time to be counting too much. They just worried about if you got a rhythm they really need to be concerned about. Bad, Kelsey. All right.
Person, I know.
All right, I'm just kidding. All right. So a little bitty box is worth how much?
0.04.
Okay, and a big box is worth 0.20 or 0.2. And so looking up here, you see the 0.04 seconds is showing you the little box. And a heavily lined box is, how many are in it?
5.
Okay, and one heavily lined box is worth 0.20. And we're measuring time going left to right when we're counting those little boxes. We're measuring time. And y'all remember we're going to look for the 3-second markers because we need how many seconds to do our rate? We need 6 seconds. And any strip I put on your test, you just assume it is 6 seconds. Okay? So if I want to get ventricular rate, what am I counting? What complexes?
QRS.
QRSs. If I'm trying to figure out what the heart rate of a patient is, we're counting QRSs. on that strip. And we're multiplying times 10. Because it's a 6-second strip, we multiply times 10 to get 60. Does that make sense? Okay, so we count rate on a patient in general, and that's ventricular rate when we're looking at heart rate by counting QRSs. So what on your EKG, we learned this in LPN school or level 2, hopefully. What complex do we measure atrial rate? What's in front of the QRS? The P. So it is the P waves that you count to get atrial rate if you have them. Okay? You with me? So atrial supposed to come before QRSs. Do you agree? Yes. If normal conduction is occurring. All right. So now, P wave is what kind of activity?
Atrial.
QRS is what kind of activity? Okay, good. T wave is what? You remember? Ventricular repolarization or rest. All right, because remember the QRS is the firing off. Okay, depolarization is firing off. This is just kind of like a little mini review. You with me? Okay, so here's what I want you to know.
Sorry, let me real quick. QRS is the ventricular depolarization.
Yes,
The T wave is the
ventricular repolarization.
sorry.
Because in order to receive another impulse, all those ions have to shift back to the resting position. So if you depolarize, you have to repolarize to have another beat. Okay? And because the ventricles are so large, or so much larger than the atria, you're going to see their waves. So that's why we see ventricular firing off, which is the QRS, and it's pretty big, and then you see the T wave, because the ventricles are pretty big. The one you don't see, your atria fire off at your P wave. Your repolarization of your atria is behind your QRS. It's like throwing rocks in the water at the same time. If my rock's bigger than your rock, whose wave in the water are you going to see? Mine. Does that make sense? Okay. So the reason I'm telling you all this is you got to kind of know this information to understand some concepts of what's going on today. All right? Okay. So, looking up here, what does the ST segment stand for? Tells you a lot about the oxygenation status of your heart muscle, doesn't it? And if it's elevated, it's infarct. And if it's depressed, ischemia. Both of them need oxygen. Okay. Now, not everyone has a U wave, this little wave right there. But if it's new and it's prominent, it could mean hypokalemia. Do y'all remember that? Okay. All right. So, if I'm looking at all, just kidding, all of the ventricular activity, does it make sense to you that I start at the QRS and I end at the T wave? Does that make sense? Okay. Do you remember, I don't know if I ever taught you this yet. Have I talked to you about the toilet?
Yeah.
Yeah. Well, no. I use the toilet a lot, so let me help you with something. All right. Here we go. This is as simple as I can make it. When an impulse is firing off or going through, trying to stimulate the heart. You with me? You with me? Impulse firing off, trying to stimulate the heart. That's called what? Depolarization. So I want you to imagine that the insides of the cell are negative in the beginning, before anything happens. Okay? like this baseline. There's nothing. It's all negative. With me? And so when firing off occurs, we flush the toilet. All right? And a lot of things start happening, and all those inside of the cells start becoming positive. So we flush the toilet. And it's very busy when we flush the toilet in the beginning. So much so that no matter what happens to that little handle, y'all know when you've tried to flush it and it don't go down and somebody's waiting, but you're trying to hit it again, right? And it ain't gonna work, is it? Because it's busy. You with me? You gotta remember this. So all the inside of that cell is positive, the toilet's flushed, it's busy. Nothing hitting on that handle is gonna work. You with me? Or affect it at all. And then you start hearing a change in the sound, right? If y'all ain't flushed your toilet, you need to go home and do it today. All right. And try to flush it again right after you flush it, unless you got some fancy toilet. Okay. You with me? And so when you start hearing that change in sound, that means that the tank's almost what? Full. So I want you to think all those ions are now shifting out back to the negative. All right? So the tank's filling up with water. Inside the heart, all those cells are shifting back negative because they have to kind of be more negative to receive or react to another stimulus. Okay? Because I said you have to repolarize, rest, everything has to shift back negative in order for it to do it again. You with me? So does the toilet kind of help? And the reason I'm telling you about the toilet is we're going to talk about synchronized. When you're in sync with something, what does that mean? The right timing. It's timing. Synchronization. Lord, if you don't want to teach Miss Cooper how to dance because she can't synchronize nothing. But synchronization is the big word when you say cardioversion. Don't say cardioversion without saying synchronize. It has to be synchronized. And on your shot box, the button says sync. Because during cardioversion, are people dead or alive?
They're alive.
They're alive. Okay, don't laugh at me. You can't use the sync button if they're dead. It's not going to work. Because the computer's only so smart as to be looking for QRS waves. So then synchronized cardioversion, the machine syncs to the QRS complex. So patients have to have a QRS complex in order to sync with. And they have to have a pulse. So there's two things that your patient has to have in order to cardiovert them in general. They have to have a pulse and they have to have a QRS. Okay? And the reason I told you the toilet story is this. I just said that when synchronized cardioversion, we are syncing with the QRSs, didn't I? Mm-hmm. Your machine, there's a video I posted about atrial fib, and it shows you a cardioversion. And it shows you the machine syncing or making little flags on top of the QRSs. All right? So the machine is going, I will not fire until I can hit exactly on the top of this QRS. It's actually milliseconds after it, but I don't count milliseconds. I'm good to count a second. You hear me? So it's pretty much firing at the QRS. And the reason is the toilet is busy at the QRS. It's firing off. The toilet's flushed. So that when that machine says wham and it hits, pow, the heart, the regular conduction system, your normal conduction system, will not be affected. All right? It stuns any abnormal impulses. And the abnormal impulses go, what? And the sinus node says, hey, no bullies here anymore. I'm the fastest. I'm supposed to be pacing this heart. And it says, let me take that over. Bully's gone. Okay. So that's how synchronized cardioversion works. The problem and the safety part, and remember, NCLEX tests safety, and who else tests safety? You. The safety issue is that there's two of them. We forget to hit the sync button, and we hit shock. What if we didn't sync? Here's the danger.
It throws her heart into a different rhythm.
All right, so, and this is why. Let's talk about the toilet again. If we didn't sync when we shocked, and we hit anywhere where the toilet's almost filled up, which is on the downslope of this T wave. Remember, the T wave is what? Ventricular rest or repolarization. It's kind of like the toilet's almost full. Guess what happens if you hit it when the toilet's almost full? Does it respond and flush? It does. You need to try it when you go home. And if I shock anywhere on the downslope of this T wave, your normal conduction can react. And how it's going to react, we call that the vulnerable period of the heart. That downslope of the T wave is your vulnerable period of your heart. Okay? I'm always vulnerable when my in-laws visit. Vulnerable period of your heart. So, if I shock on the downslope of the T by accident, I'm going to throw this patient into V-fib, which is a dead rhythm. And it happens. We've all done it. If you do it as long as we have in an emergency, you're going to forget. And you won't forget the first time. Because we all go, everybody got the sync button. We're all ready the first time. What happens, let me tell you what happens so this makes sense to you. All defibrillators have a default. So that when you synchronize the first shock, it defaults off. The sync button turns itself off. So if the first shock is ineffective and does not change the rhythm, then the doctor will say, okay, charge up a little higher, go on up to 150, 200. And we do that, and we get all excited because he's going, let's go. And we forget to hit the sync button again. And then we just shock, and guess what we put him into? Dead rhythm. We have a real code. And that is why your machines default off, because if a person is dead and you have the sync button on, it won't shock at all because it's going, the sync is going, I'm looking for the QRS. I cannot shock till I see the QRS. That's why it defaults off. In case we put them into a dead rhythm, then we can go ahead and immediately just defibrillate, because what we do for people who are dead is we don't sync nothing. There ain't nothing to sync with. We just shock. Make sense? Okay. So tell me this. When you're synchronized cardioversion, what do we sync with?
QRS.
The QRS. And we do that because we know that's the safe area to put a shock in someone who's alive. Make sense? Using the toilet phenomenon? Okay. So where's the dangerous period that we do not want to shock at?
The downslope of the T wave.
Downslope of the T wave. All right. So are you kind of understanding why you had to learn depolarization, repolarization, that kind of stuff? Okay. So when we defibrillate someone, there's a difference between defibrillation and synchronized cardioversion. The big one is you synchronize cardioversion. Synchronize cardiovert people who are alive and have QRSs. You defibrillate dead people. Dead rhythms. Because that impulse that we're sending that electricity is going to depolarize the entire myocardium. It is going to send shock at any time all the way through. Okay? So you defibrillate what kind of people? You synchronize cardiovert alive people with a pulse with a QRS. And you ready for this? This is one more thing that might help you. We synchronize cardiovert fast rhythms. Okay? Now on the flip side, I told you that defibrillator does three things. Your shock box does three things. It's all electricity. Do you agree? Mm-hmm. So we can defibrillate, which means we just shock. We can synchronize cardiovert, alive people with a QRS and a pulse, and they're fast rhythms. And then we can pace slow rhythms. And those are all forms of electricity. You got it? That is the most simple that I know how in my body to put that out to you. Okay? You can read it later in the book and all that, but it'll be a little more complex, but it'll make a lot of sense. Okay? All right, the two issues are, sorry, thank you. The two issues are, you don't want to shock someone, right? You shock them, you gotta make sure you have the sync button turned on. Remember that? Mm-hmm. And then you don't want to accidentally shock a coworker. Clear. Because you didn't say clear. Anytime, listen to me, that you are using a shock box, anytime, if you are synchronized cardioverting or defibrillating, you have to say, it's like having your hand on the trigger of a gun. Because as soon as you hit shock, anybody, and I was the world's worst in a coat because I always wear a jacket full of stuff. So they would make me strip in any coat. Take it off, Cooper, take it off. Because they knew I was going to be up on that bed somewhere. And my jacket, if my jacket is touching anywhere on that bed, when they shock, guess who gets shocked? Mm-hmm. Me. And anybody touching me. Okay? My hair ain't kinky I'm telling you, I've earned it over the years. And what the problem with getting shocked as the nurse or the healthcare provider at the bedside, you get it bad enough, you're going to be in VFib if it hits you at the wrong spot. Mm-hmm. I've been knocked down. I actually had to bring a respiratory therapist to the unit because we put her in VFib. And we had to code her along with the patient. And I ended up having to find something to drag her to the ICU with. I've had that happen in my career. I've had more fun in my career, and it wasn't funny. I kissed her right in the mouth when she woke up. She went, "My God." I said, "I'm scared the hell out of me." And I didn't do it, but I was the one in the code helping, and I had to take care of her, and I loved her to death. And so I'm just here to tell you, is that a safety issue? Yes. So saying clear before you hit the shock button, whether it's sync cardioversion or defibrillation, is huge. All right? The other thing is make sure the sync button is activated if you are doing synchronized cardioversion on someone who's alive with a pulse. Got it? All right. So you understand your review. So tell me something. What are the steps in just, if we were just going to analyze a rhythm, do you remember the steps? Is it regular or irregular? Y'all know what that means. Are the QRSs equally spaced apart? What's the rate? And coming from the sinus, it should be 60 to 100. Remember that? Yep. Coming from the junction, it should be 40 to 60. Y'all remember that? Ventricles, we hope not. We ain't going to go there today. All right. So you got the rate, you got the rhythm. What else do we need to do? Measure the PR interval. What's a normal PR interval? One big box, Kelsey.
2 seconds. 0.2 seconds, whatever.
All right, it would be 0.12 to 0.20. And the cheat method is just make sure that PR interval is within one big box. Okay? Which is 0.2. And here's Miss Cooper, how she does it. The QRS is it's skinny, which means it's narrow. All right, this one's narrow. You see how it's skinny? Which means that did it take long for it to go through the ventricles? Because we're measuring time left to right. You with me? Okay. And so we gotta look at that. And if it is normal sinus rhythm, should there be a P married to every QRS?
Yes.
Yes. All right. Just checking. So now heart rate, do you remember how we did it? We made sure we got 6 seconds, which is the bottom. So the entire strip is 6 seconds. You with me? And yours will be. You won't even have to think about it on your test, okay? What's the rate up here? 80. Okay. Is there a P married to every QRS? Yes. And find this one right here, the second one right here, is within one big box, PR interval. We start measuring it where the P comes up and the QRS starts. Is that within one big box? So that would have to be no longer than 0.20. You with me? Is the QRS skinny? What would be too wide? More than 3 little boxes, okay? 3 times 0.4 is 0.12. I'll let you have 4. Okay, and I don't stress over it. Is it skinny or wide? You're going to know if it's wide. Okay? That's skinny. Just a couple of boxes. Okay, so how would you classify that?
Normal sinus rhythm.
Normal sinus rhythm, 80. Okay. Look at the top one. What's wrong with that?
It's tacky.
Huh?
It's not even.
It's artifact. That means
I was
something.
gonna say, you gotta let the boob for that.
There's something causing trouble. No. Okay, so the problem, we see this a couple of different reasons. One, there's an electrical cord that might be interfering. Another is a big old boob might be interfering. Another one is the patient shivering because they're freezing and there's a lot of movement. But that needs to be corrected before we would actually print one off, and it needs to be corrected in order to get an accurate reading. So look at the bottom. All right. God bless you. God bless you. All right. So let's do what we know how. I see 3-second markers down here. Do y'all see them? So there's 6 seconds.
Bless
So
you.
God, devil's gonna catch you. But my grandma used to say if you kept sneezing, I was like,
No, that's 2 different people.
I know, but she did it more than once.
Nobody else gets any. She's all.
Your
blessed
grandma's
out.
supposed to tell you that. Okay. I know. She was trying to scare me from sneezing again. Thanks, Grandma. All right. Increase intracranial pressure. She was trying to tell me. Okay. So look it up here. You with me? Y'all with me? All right. Don't lose. I don't want to lose you yet. All right. What's the rate? 100. All right. Do we have P's for every QRS?
Yep.
They all kind of look the same. Do we have a P wave somewhere close to a line? Not really, huh? There's like 4. That's fine. 4 times 0.04 is 0.16. Is that less than 0.20? So the PR interval is normal. The QRS is skinny because look in here. You know, they maybe 2 boxes if you count all the way to here. Who cares? It's skinny. You with me? So that's coming from my sinus node, but the rate is too fast if it's 110. So that would be sinus tach. So you got it? So far, this is recap because you got to know normal so you can recognize when it's not coming from the sinus node.
It's only 100.
It's only 100.
Is there 100?
Yeah.
I might have added
It's not
you.
110.
Are you sure?
Yeah,
I got it.
10 times 10 is 100.
You were just trying to see if they were awake.
Okay. I counted 11. So you gotta watch. Math's not her thing. So if it's 100, it's normal sinus rhythm. You with me? Okay. All right, here's some more sinus rhythms. But there's something wrong with the top one.
Mm-hmm. Sure, that's not even.
So if you look at the 6 seconds and only count the ones in the 6 seconds, now y'all are making me really check myself. This is what happens when you don't use notes. There's 12 within the 6 second marks. Do y'all see them? Yeah. At the top, you have to draw lines and only count the ones inside them. All right? So I like to show you that because people will pull these strips this long and go, look at this, and you're trying to figure out what the rate is. Look for your marks, okay? And so that's 120 up there. Y'all see that? Do we have P's married to every QRS? Yeah, kind of look the same, but, and that looks like the PR intervals within one big box. QRSs are skinny, so that's coming from a sinus node. But what's wrong here is
There's shorter QRS complexes on some of them.
on some of them, which could mean that you got a loose connection. Could mean a lot of things. But what about that ST segment? Is it kind of, I would have to look at that in another lead and really count how many boxes that was to see if it's significant or not. But that would make me look at it again. I would do a double take and check it in another lead. All right, that's sinus rhythm, and if it is 120, it's sinus. Okay, so looking within these 6, it's hard to see this one, ain't it? Within these 6 seconds, right here, we're not going to count this one, okay? Y'all with me? 1, 2, 3, 4, 5. You agree? So if it's 50, what's wrong? All right. All right, holy cow. I like doing PACs before I do this one, but that's okay. This ain't my thing. But I can teach it backwards and forwards, so it doesn't matter. All right. Look at this. What's wrong? Look at the strip at the bottom. You got a narrow QRS, which tells me when you see a narrow QRS, it means the impulse traveled down through the ventricle spine. And it also tells you that that impulse came from somewhere above the ventricles when you see a narrow, skinny QRS, okay? You remember that? That'll be helpful. So what's above the ventricles? Atrium. Ordinarily, in sinus rhythm, you have one P wave married to every what? QRS complex. Is that the case up here? No. So if the QRS is ventricular activity, what's in front of it? Atrial activity. So instead of having P waves now, we have something called flutter waves, which is still like P waves. So you can call them P waves if you want to. It won't offend me. But the books are going to call them flutter waves. Don't matter. It's the same thing. But the deal is these waves are not coming from the sinus node. These waves are not coming from the sinus node. They're coming from the atria. There's an irritated site in the atria that has taken over pacing the heart. And it is so fast, we say, thank God for the AV node, because he's the gatekeeper. And he says, it's like people playing tennis. Oh my God, it'd be like me playing tennis with, what's her name? Serena. Heaven help. And yeah, I was good at one time. I couldn't play it now, but I used to be good. And so think about Serena now. Here she is. She's one person. And she is, and she is, y'all think about her, just one little site irritated with her ball, and she's hitting it to me. And I'm like, oh God. And I might get one every once in a while. You hear me? So this is what's happening. All right, so how many QRSs are up here? Just pretend this is a 6-second strip. 10. And I see at least 2 flutter waves for every 1 QRS. Do y'all? Mm-hmm. So if the ventricular weight is 100, we can multiply to get our atrial rate. Oh my God, the atrial rate, if that's 2 up there, is what? 200. So that little atrial irritated site is firing off 200 times. So do you think your atria is not quivering yet, But do you think it can really squeeze good and get all that blood down at a rate of 200? No. So with atrial flutter, we also have the problem that some blood may pool and clot. Luckily, the problem, or not really a problem, the limitation of atrial flutter in most patients is that it is short-lived. It is short-lived. Typically, if a patient stays in atrial flutter greater than 24 hours, it's unusual. And it takes, with science studies, most people, it takes 48 hours for clots to form. They use the rule of thumb of 48 hours. 48 hours. So if I told you that atrial flutter patients don't stay in this long, they convert back to sinus rhythm, or they go into atrial fib. Okay, and they can flip-flop back and forth in rhythms, by the way. And that makes us crazy, because we want them to get in one and do what? Stay there. Okay, so look up here. There's some things about atrial flutter that you can tell it by just looking at it. Number one, I did not say all, you heard me say most. Atrial flutter is regular. So what does that mean? The ventricular response is regular. So your QRSs are going to be equally spaced apart. Do y'all see that? So is the rhythm, remember the first step, a lot of times when I'm looking at rhythms, other than rate, the next thing we do is what? The rhythm. Is it regular or irregular? This one is regular. So atrial flutter is regular 9 times out of 10. And on any test you're going to have from me, it will be regular. And all the tests I've ever had on atrial flutter since I've been a nurse have been regular. So take that one to the bank. Atrial flutter is going to be regular. And if you look at the atrial activity in front of the QRS, it's going to look like a new chainsaw. Because it's going to be nice. It'll be, most of the time it's 2. It can be bunches.
Oh, I said 2.
Oh, I thought you said 2. A lot of times it is 2. But it could look like a nice young person's beautiful tooth. Okay, you with me? All right.
So is this a problem? Like if we see it, because you said it doesn't last more than 24 hours.
It's
usually.
a problem because it's telling you something. It's telling you that there is irritation in their atria.
Okay.
Because if there's a site in their atria, sorry, one of my students that has graduated, all right, trying to get a job somewhere else. Okay, my bad. Squirrel. All right, so looking up here, looking at the rhythm, it's regular. What else did you see? It's what? Does it look like a sawtooth? Okay, with this one, I want you to put in your mind in atrial flutter, there is one site irritated in the atria, and it is taking over, and your AV node is blocking, not letting all of the impulses through. Is that a good thing? Because what if your AV node didn't block those atrial impulses and they all went down to the ventricle? What would the heart rate be? 200. So in atrial flutter, your patient may lose a little of their cardiac output because they've lost that what? They probably lost some of their atrial kick. Do y'all remember what that word means? That means that blood from a good atrial contraction is called an atrial kick, by the way, when you're reading. All right. So in atrial flutter is short-lived. Remember I said that? And this one's going to convert either back to sinus rhythm or go into atrial fib. And that's probably why they didn't even put it in your book too much. But you're going to see patients with this at clinical. So you're going to have a rapid, regular atrial rhythm, which is this. Do you see your sawtooth? Okay. Look at the causes of it. This is where I want to go with this. sympathetic nervous system stimulation. Anxiety. Caffeine. ETOH intake, alcohol intake. So that would be people like you. Or people like my friend's son, my friend who works in ICU's son, who went and got drunk and did the funnel thing and drank too much alcohol and ended up in atrial flutter, and he ended up in the ER, and they called his mom because they knew him, and he did not want his mom called, but he was what? A minor. And so the mom said, I'm going to kill him. And I said, do not kill him. I'm going to get dressed and come up there with you. And so she goes to the ER physician and says, he ain't been in it long, I promise. It's because I know what he was doing. And he hadn't had time for blood to clot. So go ahead and shock him out of it. And he needs no sedation. And he will never drink again. They call that holiday heart. So you can actually, from alcohol intoxication, have this or atrial fib, by the way. And so he never drank again, and the ER nurses felt bad. He was still a little bit intoxicated, and them ER nurses wanted to give him something so bad, but she would not let him. And he was cardioverted, synchronized cardioverted, out of this rhythm, and he never drank again. Just saying. So, atrial flutter, is it short-lived most of the time?
Yes.
Do they lose some of their output?
Yes.
Yes. Is it a regular rhythm?
Yes.
You know how you have to learn your ABCs and your Ds, and they all look a certain way? This would be one of those rhythms you ought to be able to look at and see that sawtooth in front of those narrow QRSs over time, and should be able to get. Now, I talked about healthy hearts as the reason so far why people go into atrial flutter, right? There's also other reasons that more of what you're going to see is those clients who have sick hearts, that have coronary artery disease of some sort, that have had an MI, that have had a pulmonary embolus of some sort, who have had something wrong with them. They have valvular disease, rheumatic heart disease. They can go into atrial flutter too. There are many reasons for people going into atrial flutter. I don't want you to think that everybody is because they're drinkers or they're at high anxiety or sympathetic nervous system stimulation.
So we have the two P waves in the QRS, but what happens to the ST segment T wave? Is the heart
You just can't see it because it's fluttering right through there.
Is it not resting at all?
Yeah, it's resting. It has to. You have to repolarize in order to receive it.
That's what I was wondering.
Yeah. It's just with these waves, we're looking at electrical impulses, so you can't always see them. And that's the other thing. Sometimes, and I'm glad you brought that up, actually, sometimes you're going to see a T wave, and you'll know it's a T wave because it looks different than the flutter wave. So, you know, when you go to the hospital, you're going to hate me sometimes because you're going to be like, that's not as easy as you make it look up there. Because just like we're all humans and we look a little different, everybody's EKG looks a little bit different too. All right? Okay. So look up here. Here's another one, an atrial flutter. Do you see how, number one, is it regular? Let's go through our steps. Is there a P with every QRS? There's too many of them in there for this to be sinus rhythm. That's how we do. We're looking for sinus rhythm. Is that sinus rhythm? No. But it's regular. Tell me how many P's when it comes back up do you see? Three. What's the ventricular rate? 80. So 3 times 80.
240.
So the atrial rate is 240. And thank God for the AV note because he's only letting through. He's not letting them all through, right? So what's this called? Atrial flutter 80. The ventricular response is what is going to determine how the patient feels. If the ventricular response goes above 100, then the patient loses more cardiac output. And the more cardiac output that they lose, the weaker they're going to feel. They're going to start feeling short of breath. And then they may have those other signs and symptoms of decreased cardiac output, right? Change in LOC, a little bit of chest tightness. So I just want to make sure, I'm not going to, since atrial flutter is not in your book, I'm not going to stress over that so much, all right? So the one that I want you to stress over, not really, but the one I want you to learn the most, did I say that? The one I want you to learn the most is atrial fib, because it is the most common chronic arrhythmia that we see. And if you don't know what it is and you're in ICU or on the heart floor and they're asking you, if it's irregular, meaning the QRSs are not equally spaced apart, just guess atrial fib. You're probably right. Okay? In atrial fib, here's the difference. Instead of Serena hitting off the impulse, instead of one irritated site, now we have multiple sites firing off from the atria. Not just one. The sinus node is not in control anymore. There's some irritated site with an S, plural, bunches of them, in the atria that are firing off all at once. Holy cow. Okay? And because, remember how I was teasing and telling you with Serena that I might could stop, because maybe I'm good at it. I could stop them regularly. Y'all remember that if it's one site? What if I had all of the players playing me? I'm the AV node, and I got Serena and Venus and all those other players that I don't know their names because they're from other countries, hitting balls at me, and I am the poor AV node. Then I can't regularly let something through, can I? Because I'm doing this. That's why atrial fib is irregular, is because there's more than one site irritated. And when you look at it, we can count ventricular rate by counting within the 6-second marker. So we'll count this one. We'll just go ahead and count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And we won't count the last one for fairness. So 10. So the ventricular response rate is 100. Now, I can't even figure out how to count this mess. Can you? Because I don't know what a P is, what a T is. None of the P waves look alike. And we know that if it was sinus rhythm, it'd be what? Regular, and there'd be a P wave married to a QRS. Do we have issues up here? Yeah. We got big issues. So the problem here is you cannot, the rate is so fast, you're not even going to be able to count it, the atrial rate. Because the atria the rate is so fast that the atria is doing this. It's not just one area that's firing off, it's multitudes. So you're talking about 300 to 600 a minute. So again, the danger here is it's not organized at all, is it? So blood clots can form. And what's the hours I gave you? 48. Now, why are you saying that, Miss Cooper? Here's the deal. Let me give you a for instance of a patient that would come in to the ER or to the doctor's office. And they say to the doctor, you know, yesterday I washed my wife's car, my car, I mowed the grass. I worked all day in the yard. I felt fine. This morning, I am short of breath walking to the bathroom. Well, maybe. He's not complaining of chest pain. He's not having any other symptoms other than I am so darn weak, I can't hardly go. So at the ER or the doctor's office, they go, oh my. So they're getting vital signs, checking O2 sat. They're hooking them to the monitor, getting a 12 lead. You with me? They hook him up and they see atrial fib. When do you think he went into the atrial fib if that is nowhere in this person's history? Last night. So is that less than 48 hours? Yeah. So you kind of see where history is going to drive the clinical picture. Now they still might, because we like to cover our butts in healthcare, do a little echo and make sure they don't see anything else going on in that heart. But we could try to use some electricity to shock this patient out of this rhythm, because we would not fear that clots have done what? Had time to form. So when you're reading and you read something about 48 hours, that's what they're telling you. Okay? Does that make sense? But hello, what kind of patients do we see out there? They don't even remember what they ate yesterday. They don't remember how long it's been. You can't trust them. And that is why we do things like TEEs and check to make sure there's no clots before we try to convert them. That's why we do the 2-for-1 special in the cath lab a lot of times. Make sense? Make sense?
Yeah.
Okay, so looking up here, we really can't, they don't call these P waves anymore because are they coming from the sinus node? They'll call them fibrillatory waves. So the heart rhythm is irregular. So with atrial fib, one of the big key indicators is the QRSs are not equally spaced apart. It is irregular. Got that? And then the baseline is chaotic. And you can't tell a P from a T. Do y'all see that? Okay. So there's another rhythm that you're going to learn next semester. And you will get these two confused. And I will just laugh at you. Because right now in your mind, if you took away the QRSs, completely took it away, it would be nothing but a chaotic baseline. Do you agree? So, again, that would be VFib if I had no QRSs. It would be ventricular fibrillation. Because I have QRSs, I know the impulse came, I have skinny QRSs. The impulse came from above the ventricles. So what is above your ventricles? Atrial. So this is atrial fibrillation. And if you look at the atrial area on this strip, there's nothing organized. It's chaotic. So what do you think the activity in the atria is doing? It's chaotic. So fibrillating. So atrial fibrillation. You're just going to have to study this and write you notes saying that the rhythm is irregular and that the baseline is chaotic. When you can't determine a P from a T, then tell yourself if it's irregular, what is it? Atrial fib. And how do you know the rate? You count the QRSs and multiply times 10. All right, and if you miss something like that, I'm going to scream. All right, so again, the patient feels bad if the ventricular response is rapid, greater than 100. And patients get admitted every day for atrial fib with rapid ventricular response. They don't get just admitted with atrial fib, typically, because people live in atrial fib for years and years and years. But their ventricular rate is controlled. What's the problem if their ventricular rate goes up, you guys? What happens to their cardiac output?
Decreased.
Goes down. Then is that a problem? Yes. Okay. So look up here. You've lost your atrial kick, which means you've lost that blood that is supposed to be contracted down into the ventricles, right? You can lose up to 30% of your cardiac output in atrial fib. That's a good bit. And then look at the causes. Typically, in a sick heart, the causes are what? Coronary artery disease are up on the slide. Acute MI, infection. There's other reasons. Okay, like my friend's child, he could have been in atrial fib drinking that much. Typically, we see bladder first. Not always. So, with atrial fib, the problem is clots. So is anticoagulation very important to these patients?
Yes.
Now, you're going to find that doctors make the decision benefit versus risk with anticoagulation. All right? So some patients are only going to be on aspirin. Some patients are going to be on warfarin. If it's not associated, because sometimes atrial fib is associated with a valvular disorder. We're going to discuss valvular disorders and why that might be a little bit later. okay? If it's not associated with a valve disorder, they may put them on what they call a novel anticoagulant, which is the newer ones that you see, like Xarelto, Pradaxa, Eliquis. Those are also anticoagulants, but they do not require lab monitoring. Do y'all remember those? Those scare me with older people. One, because they're new. Two, because there's no lab to monitor it, to see if it's where it's at. You know what I mean? The other thing is they finally come out with Pradaxa has a reversal agent called Praxbind, if you've read, but it's the only one. So it's frightening. And so a lot of times when you have an atrial fib patient, they're going to be on warfarin. And they'll go with warfarin if they have a valve disorder. But the whole point is here, with an anticoagulant, what do you have to do a lot? You have to do labs. You have to explain to the patient, and they don't get it. They think they can just call the doctor and tell them how much to take today. No. What do they need? Lab. They got to follow up with their lab appointments. Lab, they got to go to the lab. All right. The other thing with atrial fib that we worry about is that they're going to have what? Stroke. How do you know someone's having a stroke? Slurred speech or some sort of speech alteration? Because they may just start talking and saying weird words. That's still a stroke. Any kind of speech alteration, slurred speech, weakness on one side. Yeah, you can do the whole fast thing, face, arms, speech. Okay, y'all remember? Okay. So is that important? Can they throw a clot, not just to their brain, to somewhere else? Yes. Oh, yes. So clots are a problem. All right, I think we got 5 minutes, y'all. I'm trying to get you to there. Get you to the pee pot. Hang on. I don't think they're breaking on time, do you? Okay. It don't matter. We're going at the top of the hour. Is there lunch? I'm hungry. Okay, looking up here. Look at this strip. Does it look a little different than the other strips? So let's use what we know how to do, you guys. Is it regular? No. So it ain't sinus rhythm, and if it is, there's something wrong with the sinus rhythm. But if it was sinus rhythm, we would have a P that looks the same, Mary Gabber QRS. Is that what you see? No. No. All right. So with sinus rhythm, we got PR intervals to measure. I can't figure out what's a P or a T. Remember, that's a hint. If you can't figure out what a P or a T is, you start thinking atrial fib. Irregular. And then you take away the QRSs in your mind. Would that be a chaotic baseline? Mm-hmm. All right, so atrial fib, what's the rate? 90. All right. Now we're going to talk about PACs real quick because they're easy. PACs are not a rhythm. They are an ectopic site somewhere in the atria that are jumping in, going, hurry up! You ain't doing it fast enough. And then they're too lazy to take over. So the sinus node goes, what was that? And so there's just a little bit of a pause or delay. And then the sinus node is going to pick back up. And then you'll be going along, and then that darn thing says, hurry up! Jumps in again. It's like jumping in my jump rope. Stop it. And when you jump in somebody's jump rope, is it regular? Unless they're real good, they might can. Is it regular? So the rate now is going to be irregular, but it's coming from the sinus node. So then we start going, did something jump in early? And that's how we can tell. But looking up here, again, is all the same things. You're going to notice all the same things that irritate the heart, which are nicotine, caffeine, any kind of stimulant, alcohol, all the things we like, right? High anxiety we don't like. And the person may start to feel what?
Palpitations.
Palpitations, because they're feeling something that's not right. So look up here. All right, go from left to right, looking at the lead on the top. So we got an upright P, QRS, and a T. The next one does not look. Does it look okay? I guess it does.
Yeah.
All right, there's 2. There's 3. Look at number 4. Do y'all see it? Do you see the difference? You almost don't see a P, do you, for that one? And here's how you can tell if this is a PAC. Take paper and put 2 little hash marks where your first 2 QRSs are. Walk them over. They shouldn't be any more than a feet off, but you can actually see where the 4th one jumped in early. But can you see that sinus rhythm with just one extra one up there? And do you see the little pause after it? Where the sinus node goes, what? And then the sinus node takes back over. So that is sinus rhythm, because PACs are not a rhythm, they're just an irritated site jumping in. And we can tell a PAC from a PVC, because PVCs are going to be wide, weird-looking QRSs. And PACs, the QRS is going to be narrow, and you'll see a little bit of a P wave. It won't look the same as the others, no, it won't. All right, so PACs, what do we teach people who are having PACs?
With doing the stimulants.
Abstain from caffeine or any stimulants. And with PACs, we treat the cause. Because there are other things that can cause PACs, such as fluid overload. Do y'all remember that? And we give them furosemide, or the other thing that can cause PACs is anxiety, and we can give them something for anxiety. All right. So when the PACs totally take over, something totally takes over, and it's not atrial flutter and it's not atrial fib, this is what it looks like. We call it SVT. In SVT, there's an irritated site that is taken over, pacing the heart. It's not the sinus node. And the problem is the rate. And the reason we can tell this from sinus tachycardia, this is something that when I used to teach at the hospital, routine nurses that have been nurses 15 years say to me, it's hard to tell the difference between SVT and sinus tach. Do you know what the difference is?
What is it?
SVT, boom, comes on real fast. It just happens all of a sudden. So your patient's going to say, all of a sudden my heart's just running away from me. Sinus tach comes on gradually, okay? Sinus tach happens because of fever, because they have fluid volume deficit over time, because they're hurting, because they're exercising. SVT is something that just, bam, comes on, all right? And they'll say they can't catch their breath. And so, you with me on the difference? Okay, so with SVT, what's the rate up here between these 6 seconds? Is it about 160 between there?
Yeah.
It's about 160. Typically, sinus rhythm, sinus tach, when someone's in sinus tachycardia, their rate is typically below 150. When you have rates above 150, you need to be thinking, could this be SVT? Unless you know they've been in sinus tach and you've not done anything to correct it and it just keeps walking up. You with me? Okay. So what we call SVT is narrow complex tach. When I say narrow complex, I'm talking about the QRS, and that will serve you well if you can remember that, because as you further your learning, that's what they're going to say on all these sites is narrow complex tach. So they're talking about the QRS being narrow, which tells you if the QRS is narrow that the impulse originated somewhere above the ventricles. You with me? Okay. It's time to eat, people. When you come back, we'll pick up right there.